a little bit about it. Thank you. I forgot to make note. We will be recording this because it will be posted on our website along with the slides and some data and our FAQ. But thanks everyone for joining. We are gathered today to talk about implementation of 1227, as well as some data around what we're seeing for a first quarter of implementation. We're going to talk a little bit about the bill, the data, our practice and implementation plan around that, and then sort of what we're seeing and what we're seeing as needs for families across our state. I'm excited to be joined by my colleagues, Interim Assistant Secretary of Prevention, Partnership, and Services, Dr. Vicki Ibarra, and Doreen, I'm going to get your title wrong, but Deputy Assistant Secretary for Child Welfare Field Operations. Did I get it right? Doreen Perez. Unfortunately, Assistant Secretary Natalie Green had a emergency this weekend and was not able to join us, but we're excited to have Doreen here to step in and move through this. The goal today is really to talk through the realities of what we're seeing now that we're a quarter into implementation of 1227. The law change took effect last year. And if we want to go ahead and go to the next slide, a little bit about format. We're in a question and answer format. There's a Q&A button at the bottom of your screen. Please feel free to type questions in. We'll respond to some questions as we go, probably live and verbally. We may type answers to others. You'll be able to see all those. If there's questions we don't know the answer to, we certainly will not make it up, but we'll follow up with an FAQ or a posted Q&A on the website after the webinar. So our goals today are to provide information on how we're implementing the Keeping Families Together Act, share some preliminary data on what we're seeing with the change in the removal standard. We also want to spend some time talking about the relationship between fentanyl and increasing critical incidences. So in addition to 1227 going live, we are in the middle of a fentanyl epidemic across our state and the nation, and want to talk about that, and then talk about our urgent needs and what we see as urgent needs for our clients, our staff, and where we're headed. So with that, we can go ahead and go to the next slide. And I will, there's our agenda. We're using a slide deck. This is Doreen presenting today, not Natalie. We'll get that shifted, but no worries. And with that, I will turn it over to, we go to the next slide. I'll turn it over to Doreen.
Thank you, Allison. As most of you know, the Keeping Families Together Act was passed in 2021, and it went into effect this past July of 23. And the intent of this was to safely reduce the number of children who are in foster care, reduce racial disproportionality. Can we go back to the, thank you. Reduce racial disproportionality in the child welfare system and support placement with relatives when children must be placed out of home. Next slide. What this did was change the legal standards to remove a child through a hospital hold, law enforcement hold, or pickup order and a shelter care order. And it requires us as DCYF and the courts to place children with relatives unless no relative is available who can protect the basic safety of the child. This allows courts to order us, DCYF, to issue initial licenses to those relatives and provide supports to relatives to become licensed. Now, the change in the removal standards, this was intended to prevent removing children due to risk alone. And as you all know, risk is the likelihood of future maltreatment. Whereas when we're identifying the safety threat, we are really honing in on what is the present or imminent danger to the child. With risk, we're looking at harm over time. And with the safety threat, we're looking at, and the changes due to 1227, physically, what's harmful result in the very near future. Additionally, with risk, previously, the statute indicated that serious threat of substantial harm may have included high-risk situations where there's a likelihood of severe harm in the future or over time. Now, under 1227, the statute indicates imminent physical harm, and this may be interpreted more narrowly regarding the immediacy of the danger to the child, and that's what we focus on now. How are we implementing this? Since 2022, we have been convening a huge number of stakeholder work groups to recommend strategies to meet this requirement and its intent. And we incorporated many of these recommendations into those key projects that live under the Thriving Families campaign. And this focuses on prevention, supporting families and staff, and strengthening our practice. So as you can see in the PowerPoint presentation, we did a lot of convening between January and June of last year. Then in December of this year, we launched our Foundations of Practice, which all of you should have participated in at least a few, if not all of those, because that was really giving you the foundation you needed and the training that you needed to be able to maneuver within 1227. Then in March, and I believe that should be 23, not March 22, we provided some more ongoing training to you and launched the dependency petition pilot and safe child consults. So in March of 23, we provided that training to our staff and the pilot in making certain that we and the courts were able to get the information that they needed. Then in July, when that went into effect and to present, we have been engaged in collecting data, conducting some qualitative reviews to identify any needs for those adjustments to our practice. So lastly, safe child consultations are held prior to filing a dependency petition. Now, the priority for DCYF is to keep children at home by supporting the social worker, the caseworker, to put a safety plan in place if needed. We take a look at a lot of different factors that could change the recommendation for removal. And if that consultation recommends removal, this is not always going to be the final decision because we do want to have a meeting with the family, and that may change our recommendations. So we start with, we receive that safety concern, and what's new within our process is we do a safe child consultation. That can and often leads to a family team decision-making meeting where family and family supports that they self-identify come to the table, and we are able to learn more information that we may not have heard before, where we would be able to safety plan with a family effectively in their home without having to pursue removal. However, if we're not able to do that, then we do move on to having to file the dependency petition and go to our shelter care hearing. Allison, I'm not sure we're on slide 9. Is this the last slide?
That's right. So I think at this point, we will kick it over to Vicki to talk about what we're seeing as part of this. Sorry, I'm battling a cold.
Thanks, Allison. And thanks, Doreen, for laying that great foundation. So what are we seeing as a result of these changes? Well, we are seeing first and foremost that the law appears to be having its intended effect of reducing removals. We are not removing as many children at high risk, and those children are with their families in their communities. As Doreen said, we have completed some internal qualitative case reviews of safe child consultations to determine whether they're being done as intended. And generally, we find that those case reviews indicate that we are taking the additional steps to prevent removal of a child and to support a safety plan for the family whenever possible. The overlap between 1227 and the plan of safe care is reducing screened-in intakes involving substance-exposed newborns. Plan of safe care was also driven by legislation separate from 1227, federal legislation, and has resulted in, we think, a decrease in the number of substance-exposed newborns, and that is separate but overlapping with the goals of 1227 implemented at about the same time. As Allison mentioned, the fentanyl crisis statewide continues to leave many children at risk, and a lack of SUD, substance abuse disorder treatment services, and other community-based supports for families also may be placing children at further risk. Next slide. This is just a slide referencing fentanyl and its dangers. I think most people on this call are likely aware of what's happening in the state. We'll present some data on fentanyl and critical incidents later in the deck. It's just important to be aware that this drug is everywhere in our state now, causing many poor outcomes that are of concern. Although drug abuse and drug challenges in the state have come in waves with previous types of drugs, we think this one is different for child safety in a number of ways. One way it's different is that People are often unaware that the drug they're consuming has fentanyl in it. It is often marketed in a way that is attractive to children, and there often are no second chances. It's a very strong and very lethal drug. Next slide, please. All right. It's important to look at the data for 1227 in context of the long-term trend. Since the agency became DCYF, since our agency was established in state fiscal 2018, Washington has seen almost a 36% reduction in the number of children in out-of-home care, and we measure that generally at a point in time. This trend is largely consistent with national trends on children in out-of-home care that have also seen a decrease since those years. Since 2020, we've seen an increased percentage of moderately high to high-risk cases being re-referred to CPS intake and screening in. So this is what we might expect. As fewer children are entering care, more children who may have been in cases that we would tag as high or moderately high risk are not being placed, and we're seeing an increased re-referral of those cases. Since 2019, we're also seeing opioid-related emergencies in the communities, and this can be seen on the Department of Health dashboard, have dramatically increased for the entire population. So these are things that are all happening at the same time as we're seeing the implementation of 1227. Next slide. So what we've seen since July 1st, and this is through about the end of September, we've seen about a 25% decrease statewide in children entering care. These are entries into care, not children in care. And there is substantial variation across the state in terms of where we're seeing the largest increases. Those are in Pierce and Yakima County have experienced the largest decreases rather of children entering care. And here you see the regional breakdown follows that, with Region 2 having the largest percentage reduction in children entering care. Region 5 has a large but a bit smaller percentage reduction of children entering care, although Region 5 has experienced the greatest number. They are a larger region, a more populous region, so the numbers there are larger. Next slide. Entries into care are down across all categories, while participation in family voluntary services is up just a bit. You can see here the comparison between this July 1st to September 29th period 2023 with the same period in 2022. And because there are seasonal variations to entries into care, it's important that we compare with the previous year for the same period of time. Voluntary placements are down. Protective custodies are down, and court-approved placements are down. At the bottom, you see FVS, or our Family Voluntary Services, which is a type of case management service that is longer term for CPS investigation cases to try to provide services to families to mitigate safety harms and prevent children from entering care. Those numbers are up a bit, although not as much as the placement numbers are down. Next slide. The largest, here's an age breakdown of the reductions in out-of-home placements. This is children entering care by age group. As might be expected, the very youngest children age group is experiencing the largest decrease in entries into care, age 0 to 1, 40% decrease, age 2 to 3, about a 9% decrease, ages 4 to 11, about an 18% decrease, and ages 12 to 17, about a 25% decrease. Washington State has for many years been among the highest states in the nation in terms of the percentage of children entering care who are in that youngest age range. Last time I checked, I think we were 3rd or 4th if you compare us to other states. So a very large portion of children entering care in Washington for a long time have been in that youngest age range. So just for that reason, it might make sense that we'd see a larger impact there. But I think the greater effect there is from the plan of safe care changes, which have happened that give give birthing hospitals a route to encourage services for families without having to involve a CPS investigation or CPS referral. Previously, birthing hospitals were referring all substance-exposed infants, even if there was not a safety concern, to CPS, and often that resulted in CPS investigation. Now they have the option to refer to community services if there is a substance-exposed infant, but no safety concerns present. So we think that's having a large impact on this age breakdown here. For those of you interested in the plan of safe care, we have updated the website. And I think I just talked over the next slide. Next slide. So more detail about the plan of safe care, a nice graphic that shows the things I just described. And we have recently updated the plan of safe care website. So it has additional information if you're interested in that. Thanks. Next slide. All right. So screened in intakes of substance exposed infants, as I mentioned, this is from 2018 to 2023, May, June, July, and August, screened in intakes. And this is not yet entries into care, but we necessarily need to have a screened in intake, then an investigation, then an entry into care. And this just shows us that at the front end, the intakes are decreasing. If we just follow the month of August, for example, we can see that from 2018 to 2022, the numbers were fairly stable, and then we had a large drop in 2023, and we believe that will likely continue. Next slide. And then this is the out-of-home placements of substance-exposed infants, also declining along the same lines. Here we don't have August for 2023 because of the data lag, but we do have July, and we can see that July, the numbers entering care decreased quite a bit from 2022 to 2023. Thanks. Next slide. All right, we've mentioned fentanyl a few times, and this is a crisis that's happening sort of in the background as context for what our communities are dealing with. The fentanyl crisis, we believe, has been a driving factor behind an increase in critical incidents involving young children in Washington. Just by way of reminder, a critical incident is a fatality or near fatality that occurs within 12 months of involvement with the child welfare system. So if they've been open to us for investigation or been placed, the statute requires that the agency complete a review on each one of these critical incidents. Next slide. Fentanyl-related critical incidents are increasing among children in Washington state and have been. Here you see the trend of total critical in-home incidents. So these are children whose incident occurred while they were with their family. There are critical incidents that occur of children in foster care, but they're very few. And in order to keep this clean, we are showing just the in-home numbers here. So here you see the trend from 2012 to 2022. 2022 was a large increase from 27 the previous year to 41 total critical incidents. This year, we've seen 32 critical incidents already, and just looking at the rate at which these are happening, we're projecting another 16, which would be 48 total, so just a bit more than 2022. These are concerning. This trend is very concerning. Some of you may have seen that OFCO, the Office of Family and Child Ombuds, recently released their most recent report on child death. They note the same increase. Next slide. Much of this increase is being driven by fentanyl-related critical incidents involving young children. On the left side, you see the total fatalities and near fatalities by age group. And just using the through August 2023 data, we can see that the 0 to 3 numbers are what drive these. The most critical incidents involve that very young child population. And then over on the right side, again, using just 2023 through August, those cases that we've actually had and that we actually can look at some information about, not the projected numbers. The numbers so far are the same, but the number involving fentanyl for that very young child population, 0 to 3, is much higher. Here we're seeing in 2022, half of those critical incidents involving children 0 to 3 involved fentanyl, but already in 2023, we're seeing the vast majority, 24, have involved fentanyl. Often this is accidental ingestion, so young children whose behavior still involves putting things in their mouths that they find, especially if they're attractive things. Often it involves accidental ingestion. Next slide. If we think about the safety risk, so Doreen talked about the two axes, safety and risk. If we think about the safety threat at the time of the assessment, their child welfare assessment, we see that the vast majority of the critical incidents are cases in which there was no safety threat indicated at the time of the assessment. And here you have detail on this: 93% no safety risk at the time of assessment, 7% yes, and 24% is what we would expect to see in the larger CPS population. Next slide. So that was the safety axis. If we look at the risk axis, we see that the vast majority of critical incidents, the risk assessment identified the situation as moderately high or high risk. And here we see the general population, we would expect to see about 66% as low or moderate, 88% were indicated as high or moderately high of the critical incident. CI here means critical incident. So we have those two axes that the agency and our workers work with: safety and risk. And 1227 put our focus on safety in terms of entries into care. The Keeping Families Together Act did not increase the availability of many of the community-based resources that support child safety and that our families need, especially substance abuse treatment. In fact, in some areas of the state, SUD treatment is actually decreasing. But our families also need other community services and supports in order for children to stay safe and for families to thrive. They need mental health and other services. They need domestic violence services. We know that the COVID-related stimulus, like the federal child tax credit, was an important form of support for families living in poverty to help prevent maltreatment related to neglect. And we know that housing costs have continued to rise. So all of these challenges are still happening in communities at the same time that high-risk families, as a result of 1227, are in the communities, and children in those high-risk families are still in the communities. With that, I'm going to turn it over to Allison.
Great. If we want to go to the next slide, Vicki, I think that was the services slide that you were describing. And then we'll pause there. Perfect. Thanks, Vicki. We're going to go, before we talk about sort of what we've done and where we're headed, there's a number of questions coming in, and probably do more justice through a verbal answer. So I'm going to read them, and then I'm going to determine in my reading of the question whether it's a Doreen question or a Vicki question. I may get it wrong, but we'll let them sort of answer. We'll start at the top. So some of this goes back to earlier parts of the conversation or the presentation. The first question, and I think this is for Doreen: if there needs to be risk of imminent physical harm, what is happening in cases of mental/emotional abuse?
That's a really good question. And so there is still the ability for social workers to articulate what is that immediate harm to a child based on that emotional and emotional neglect. And so it's really about helping our staff hone in and key in on what are the safety threats that have been activated as a result of that. And through that process, we are able to articulate what is that immediate physical harm. So physical harm, it doesn't have to necessarily be a physical to the body, but what is going to manifest as a result of this emotional abuse or this neglect. It's really more about ensuring that we are articulating that they are having different types of distresses as a result of that.
Great. Thanks, Doreen. Next question, which I'll take And answer, will Washington State be seeing, or are we seeing funds from the fentanyl lawsuits? Great question. I have not seen a fentanyl specific lawsuit, but there is the opioid settlement, in which case we are seeing the state does have a plan related to the opioid settlement that's being led by our colleagues at Healthcare Authority and DOH, and we've participated in that. So there are recommendations around opioid settlement dollars to support some of the strategies that Vicki named and some of the things we've talked about, as well as other opioid related pieces, opioid related response for the state. Vicki, there's a question, why are Pierce and Yakima seeing larger reductions?
Thanks, Ruth, for the question. It's a terrific question that many of us have asked, and the bottom line is we don't yet know. We don't have enough information to know yet. We do expect to be investigating that as we get more data, but we do have hypotheses, and many people are generating hypotheses, and that's good because then we can test them with the data when we get more data. Some hypotheses that have been suggested is that both Pierce and Yakima were early adopters for some of our larger prevention efforts. And it could be that they simply are seeing a decrease in demand for out-of-home placement related to those prevention efforts. It's also possible that they were, before 1227, that they were placing a higher portion of high and moderate high risk kids. And since those are the ones that we're seeing no longer placed, it could be that they just had more of that. Pierce and Yakima both are counties that are economically challenged and have a lot of poverty. So it could have been related to that. Those are hypotheses. We'd love to hear more. And as we get more data, I would expect that we'll be trying to actually test some of those hypotheses. Thanks.
And as a reminder on the data note, DCYF has committed to publish the data each quarter. And so after the webinar today, the data set, the deck, the recording will go online. We'll determine if we do a presentation each quarter when we roll out new data. I think it will depend on, to Vicki's point, what are we seeing? What's the data telling us? But we'll continue to publish and post this data each quarter. Next question, you said a reduction in court-approved placements. What does that mean? Vicki, I think this was on one of the data slides.
Yeah, so that was a measure that I got from the Whisker dependency dashboard. So if I use the wrong term from the courts, I apologize, but it's the court-ordered dependency that appears in the dependency dashboard, the Whisker AOC dependency dashboard.
Great.
Thanks.
There's a question that I'll take. The reviews and quarterly reports on the DCYF website, I'm assuming, have not been updated for this year, except for the first quarter of this year. When will these be updated on the DCYF website? And I think you're talking about fatality reviews and the quarterly roll-up of fatality reviews. I'll have to check and get back on timeline for Q2. We just finished Q3. I think if I have that right, yes, we've just finished Q3, and so that roll-up hasn't begun yet, but I can get back and look at and check up on the timeline for quarter 2. But you know where the link is, and as soon as they're finished, that's where they do get posted. There's a question around the critical incident data. Can this be broken down by county? I'll turn to Vicki to answer that, but my guess is because sometimes the cell sizes are so small, it may be challenging, but I'll turn to Vicki.
Yeah, so we know the counties that the critical incidents occurred in, and I believe it might even be in the qualitative reviews that are posted online. But our standard with producing data is with cell sizes under 10. We don't publish those publicly, so we're not able to publish them. But I would encourage you to take a look at the qualitative reviews to see if county is there. Thanks.
Great. Next question, and I think Doreen, this one's probably for you. Would fentanyl in the home be considered a safety risk, or what are examples of safety risks according to DCYF? And I'm wondering if what they mean is safety threats versus risk there. But you want to talk a little bit about how we look at substance use and fentanyl in the context of risk and threat?
Yes, and I'll answer that as safety threats, because we are a safety threat is when a risk has basically been activated. So lots of us have family circumstances where if there's just that one last thing that tips it over, it becomes a safety threat because there's not any kind of a safety net around us, or there's not other things that are mitigating that risk in the home. And so is fentanyl in the home considered a safety threat? It could be. And we're going to be taking a look at all the other factors involved in that. Age of the children, needs of the children. Does the family have a lockbox? That's something that our agency has really done and gone towards, is ensuring that whenever we're involved with families, that we are giving them the tools to help keep their homes safe, and putting their that stuff away and locked up. So we're going to be looking at a lot of different factors around that, and just fentanyl in the home isn't necessarily going to create that safety threat.
Doreen, the next question: who determines whether something is considered a near fatality? The statute, the RCW, outlines really clearly when the department is required to do a fatality review or a near fatality review. And we can certainly follow up with the exact RCW. I don't know it off the top of my head. I don't know, Vicki, if you have more you want to add there.
Yeah, the agency has a policy. If you go to the agency website and look up policy 6301 on fatality, near fatality reviews, it links you to the RCW and to the definition. It's certified by a physician.
Great. Thank you, Vicki. Next question: is there any data relating to instances of critical incidents on re-referrals? Are there more instances of critical incidents on re-referred cases?
That's a great question. I don't know the answer to that. It is likely lives in the qualitative information about each case. So each case likely has the child welfare history in that qualitative review, but I don't know of any quantitative data around that.
Great. Next question: one of the outcomes that some thought we would see, I think with the implementation of 1227 there, was that filings was filings where DCYF was not asking for removal, so not filing a petition for removal. It seems like families at high risk may be eligible for court intervention without separation. Are you seeing any filings across the state where this shift is happening? So I think the question, and Doreen, I'll let you sort of potentially answer and respond to the practice. And Vicki, I don't know if we have the data separated, but the question is, are we seeing a shift or an increase in filing in-home dependencies versus petitions for removal?
And from a practice perspective, it's still a little too early for us to be able to take a look at that. We have seen some filings requesting removal that result in an in-home dependency where the child remains and the court intervention remains. And we've also seen some circumstances where the dependency petition is dismissed and not accepted, but with the expectation from the court that we continue with voluntary services, but there's no court oversight for those. So we're seeing a little bit of both right now.
Next question: for an exposed infant with safety concerns who screens in for intake, but CPS still can't remove under the new law, parentheses, Pierce County is taking it to the extreme, are the babies checked on at all? And then there's some personal sort of scenario there around a daughter living in a DV and drug exposed risk situation, and we haven't heard from the mom in a while. Doreen, I think that's probably a practice question.
From a practice perspective, I would encourage anybody who has concerns about a child to please call our hotline and call those intakes in. And if they do meet the screening criteria, we would be involved in doing an investigation or a FAR, family assessment. And I'm sorry, being able to answer to this exposed infant with safety concerns without having all the information, it's not a question that's easily answered.
Yeah, I think the top line of each case is so unique. And Doreen, correct me if I'm wrong, sometimes cases will stay open in sort of that investigative phase as families are engaging in services, and they may be referred to FVS or other service exposure. And sometimes cases may be closed if there isn't sufficient thresholds to meet a filing.
Absolutely. If that case is in investigations and there is a need for ongoing services, whether we're monitoring those services or we're providing those services and monitoring them, it can be provided through voluntary services. And same with the family assessment response, where there's not a finding of abuse or neglect, but we are doing an assessment that determines that there's a need for services and or the family wants to engage in services, then we're going to be doing that and monitoring over a period of time.
Excellent. Okay, next question. For the critical incident cases with moderately high or high risk, the 88% number, do you have the percentage of families that were referred to FVS? look at you, Vicki, for service referral.
Thanks, Cody, for the question. I don't have that percentage off the top of my head. Again, I think whether the family had been referred to FES or whether the family had engaged in FES services would likely be in the qualitative reviews that we post on our website. So I encourage you to take a look at those. Thanks.
Is it possible to look at children under the age of 1 separately as compared to including them in the 0 to 3 category? And looking at child vulnerabilities, a child under the age of 1 would be vulnerable to accidental exposure very differently than a toddler. I'm not sure, Laura, if this was in specific response to specific question in response to one of the data sets. I know we did have the age broken out 0 to 1 and 2 to 3. I don't know, Vicki, if you have other thoughts.
Yeah, I think I understand what Laura's asking on the critical, I think she's referring to the critical incidents and accidental exposure. And of course, she's correct that children under age 1 would be exposed very differently than a toddler would be exposed. We have those numbers, Laura. We don't publish them because they're so small. Again, we have a whole critical incident review team that takes a look at these individually with each of the, with external partners and experts and community folks. And so they are looking at those kinds of trends. I would agree with you. We publish the qualitative information from each of those reviews for each child. We're not publishing the numbers here in that way, but those data are available and are looked at.
And then next question is asking about the overall fatality numbers with children with CPS involvement from the first quarter of last year compared to the first quarter of this year. We don't have that prepared for today in this data set. And I would imagine Vicki lives in sort of the same critical incident spaces you've referenced.
Yes.
Excellent. There's a question that I'm going to kick off the answer to and then lean on both of you to chime in. How are medical providers assessing risk? Are they basing it on what parents say? Our birth mom has delivered, maybe a foster parent, delivered at several hospitals, so they don't seem to even know how many children she has, so they can assess risk. So when we're talking about risk and what Doreen walked through and what Vicki talked about was the CPS risk assessment tool and screening tool that we use. Hospital practice and practice likely varies based on hospital. I will remind folks that all doctors, hospitals are mandated reporters. So if they think a child is at risk or in danger, they are mandated reporters to call. But I don't think it would be prudent for us to comment on sort of the behavior of the hospital or their risk. I don't know, Vicki, if you have more you want to add on plan of safe care or how a plan of safe care relates.
Yeah, I'd encourage the person who asked that question to go to the Plan of Safe Care website. And if you review the information and still have questions, there's a place for you to submit questions about Plan of Safe Care. The changes in Plan of Safe Care speak to safety threat, not risk. So the hospitals, to my understanding, are not being asked to do a risk assessment. They're being asked to consider safety threats. Thanks.
There's a couple of questions around changes around racial disproportionality around the data. I don't know, Vicki, if you want to comment on sort of where we're at and looking at disparities.
Yeah, we are definitely keeping an eye on this. As Doreen said at the beginning, one of the intents of the legislation was to reduce disproportionality, not to increase it. We do have some data. We're not publishing it yet because we still have a lot of unknowns. Early in a case is when we see the most missing data on race ethnicity. As a case is with us longer, as more time has passed, those data are more likely to be available. So we're still at something like 25% missing data. So we're not publishing it yet, but we will when the data settles a little bit. So far, it looks like Black and Black multiracial children are not experiencing the same decrease in entries into care as other groups of children.
So the question I'm going to turn to Doreen, which is likely a very complicated answer. So in 30 seconds or so, I'll let you take it. But what should a caseworker look for when deciding whether to file or a dependency case or not?
What our social work staff are doing is they're conducting a safety assessment. And that safety assessment is taking a look at the 17 identified safety threats. And if they are indicating that any of those are activated, then they go through a safety analysis. So is that able to be, is there an adult in the home who's able to mitigate the risk? Is there other factors? So they're going through this safety plan analysis to determine whether or not, number one, we can provide some mitigation in the home to prevent out-of-home placement. And if we can't, and we then have to develop a safety plan, can that safety plan be managed in the home? Again, if that can't happen, then we're looking at, do we have legal sufficiency to file? And so we do consult with our Attorney General's office to ensure that we have the legal sufficiency to do that. And as we indicated previously, we are going to be doing a safe child consult to make certain that that social worker has had the opportunity to go through all the different factors involved based on our global assessment of the family's functioning and the child's functioning. And we're going to determine whether or not, yes, we may be looking at filing. Then we're moving on to the family team decision-making meeting where we invite the family, we invite any of the family member support systems that they want, and then we will hear more and determine whether or not there really is that need to file because the child cannot be safely maintained in the home pending these services.
Will there be data collected around how many families are entering into VPAs, FAR and FVS cases as well? Yes, we did include the VPA data in the deck and the FVS cases.
And the FES cases, yes, those are all included in the deck, except FAR. FAR is not included in the deck, but the other two are.
Great. There's another question. Are we tracking the number of return to care and failed relative placement numbers? So we do look at a balancing indicator of children who come back into care. That's not in this deck, but that's something we look at ongoing. And we also do look at placement disruptions, regardless of setting. So for children who are still in care, but may have a placement disruption, we do look at those. We don't publish that data often publicly. I think that's the question there, but we are looking at those. Caseworkers are looking at those and navigating any placement disruptions that may exist for a child or youth in care. I don't know if Vicki or Doreen, you have more you want to add there.
Re-referral is one of our key indicators for quality improvement, and I believe we have some of that on our agency performance page.
Yeah, excellent. Does CPS give any support to families, relatives, grandparents that are taking on care of a young child, for example, access to daycare, respite care, financial support? Erin, great question. This varies depending on the relationship of that child in that care. So for children who come into through the potential CPS or dependency door and are placed in placed with a relative or guardian, they have access now to the initial license, which is a abbreviated license version, which triggers that foster care maintenance payment. So financial resources for that family really quickly into that placement. There's also access to support services, and we are continuing to build out the support services available to relative and kin caregivers through investments in the caregiver supports package last legislative session. If that relationship is an informal placement and wasn't engaged in the CPS or child welfare process, which we know many of those relationships are, then it is likely that family would receive support from TANF only, or our colleagues, our partners at DSHS, but not through the child welfare involved system or the CPS system or DCYF directly. They may receive ancillary support through childcare eligibility or preschool or home visiting through voluntary, but not necessarily through the CPS door unless it came in through that pathway. A couple more questions, and then we've got a couple more slides to move on to. One of the hypotheses that you mentioned was the prevention interventions in Region 2 and 5 were involved in. Can you say more about what those are and if they will be expanded to other regions?
Sure, happy to talk about that. Thanks for the question, Erin. So one big intervention that was piloted was our Child Welfare Early Learning Navigator, piloted for a number of years in just a few places in the state. Very successful, and recently we have secured funding to spread that to the rest of the state. Doreen, I've heard you mention some of the other prevention initiatives that happened in these two regions. Can you speak to some others that might be out there?
Yeah, Yakima County was one of the early adopters of the Plan of Safe Care, and so the hospital system, and that was put in place as an early pilot, and then that had expanded and has expanded across the rest of the state for the Plan of Safe Care, and that keeps a lot of those intakes that we would have normally received and potentially intervened on at the local level through the community services that are available in the hospital settings. The other things that Region 2 did in particular was they had reorganized their prevention services into one unit, and this was kind of an early adoption of the FFPSA, and there was that we saw an ability for us to be able to really hone in on the service needs of families with keeping them from penetrating further. And in Region 5, they had a couple of other pilots, and I'm sorry, I can't think of those off the top of my head, but they also were early adopters in doing some really unique prevention work there. They had a Safe Babies Court and things like that.
And some of those are expanding. Safe Babies Court is a initiative that has expanded to other jurisdictions and courts as well. So some of those strategies we are seeing expansion around. There's a question about the safety criteria hospitals are using when determining whether the intake needs to be made. They follow the requirements and laws around mandated reporting. I can't speak to individual practice around that, but they are mandated reporters and would be subject to the requirements there.
I would also refer that questioner to the Plan of Safe Care website. If our site doesn't answer your questions, there is a place you can send to get more answers.
Great, thanks, Vicki. What can people do who highly disagree with House Bill 1227 and its non-protection of our children? I would encourage you to reach out to your lawmaker. It was a bill that passed. It is law, and the way to change a law is through advocacy with the legislature. There are a couple of comments around drug paraphernalia and lockboxes, and I don't know, Doreen, if you want to clarify, but there's a comment that says if a parent has severe addiction and refuses treatment, we'll expect them to be reasonable enough to lock up their drugs. And I think this question sort of emerged from the use of lockboxes. Want to be clear that caseworkers have access to and hand out lockboxes as a harm reduction strategy. As Doreen has noted, there are a variety of factors that contribute to the decision-making around in-home supports and services or filing petitions. There, it's not so linear, I would say, or so if this, then that, as each case, each set of circumstances is different. I don't know, Doreen, if there's more you want to add there.
No, that pretty much captures it. Every case is very unique, and we're going to take a look at those circumstances. And so it's not just a standalone that they're putting their drugs away.
Thanks, Doreen. Let's see. What are the differences between Plan of Safe Care and a safety plan? So Plan of Safe Care is a federal initiative that guides hospital behavior around the birth of substance-exposed newborns. DCYF has been a partner in that work and supporting implementation of Plan of Safe Care. A safety plan is the plan a social worker, a CPS investigator might create with a family in which they have come to our attention and are engaging with and potentially doing an investigation on. Hopefully I covered safety plan closely enough. There's a question about retention data. We have social worker retention data, and we can certainly look at retention data July 1 through, we have not done that analysis yet, but we are looking at retention data. I'll let Doreen, there's a question. So it seems that DCYF is only considering safety or safety threats where there is high risk. How is that being handled? I don't know if you want to talk again and clarify what's happening there.
I'm not sure I completely understand the question. So we've always looked at safety, and this is something that has not changed. It's just a matter of focusing that in around the 1227 requirements of us now.
Vicki, there's a question about services. Are providers able to keep up with the amount of services required prior to removal? Is there added strain to accessing services to support families? I don't know if you want to talk a little bit about the service reality.
Yeah, I think there are a lot of services in the communities that families need that are not as available as we'd like them to be. I mentioned in this slide, substance abuse treatment in many communities, this access is actually decreasing. Mental health and other community-based services and housing. In terms of the contracted services that we provide, we're still trying to get a handle on what's needed where and the data around that. So lots of work to be done there. But we do think overall that we need to increase services around the state. Thanks.
Thank you. Great. So there's a couple other questions that we'll follow up with offline. I want to make sure we are able to move to sort of the where we're headed and what's next. If we want to go ahead and go to the next slide, Chelsea. So what are we doing? As noted, we're continuing to monitor the data and do deep case review of cases. informing stakeholders, allies, the legislature around the robust need for substance use disorder treatment and community-based services. We are bringing on substance use disorder professionals to support caseworkers. We'll have 12 of those that'll be embedded out and through the field that will be able to support the dynamic, the ever-changing landscape when it comes to substance use for the clients we serve. And we continue to explore the concept of a contract or contracting for third-party safety plan participants. So some families have organic and natural supports to safety plan participants. Grandparents are nearby, relatives, robust connection. And having just some extra people to relieve some of that pressure helps, and some don't. And so thinking about what creative and new innovative opportunities might help support that family. If we want to go ahead and go to the next slide and what we're asking for, it's really clear that our state needs access to more residential drug treatment and expansion of models that allow families to remain with their children. On average, we remove about 700 infants a year, although we're seeing this year that decrease. And currently there's only 156 PPI or pregnant and parenting individual beds across the state. None in Pierce and King County, which is where we see some of the biggest demand and certainly highest population numbers. Things we continue to ask for are increasing pay for the substance use disorder professionals to stay competitive, support their licensing fees, et cetera, both in our system and around the profession. Continue to ask for improved access to detox, often not provided given the amount of medical oversight needed, and then access to medication for opioid use disorder or medically assisted treatment as what it used to be called. So these are things the agency continues to ask for, in addition to the steps noted on the previous slide of things we will continue to do as we round out and live into implementation of this law. And I think that is our last slide. So I'm going to go back to some of the questions. And again, some of these will follow up and have an FAQ or have questions from the webinar that will get posted online if we don't get to them all. There's a question about what is being done to increase services available to families. I don't know, Vicki, if you want to talk a little bit about service increase.
Yeah, we have an initiative in the agency to expand services. So we're trying to look more closely at the regional and local levels to see what's needed. There are real data challenges in this space. So what we need is better data to try to help us understand what's needed and where it's needed. But the services we've talked about up to this point, certainly we know are needed broadly across the state: substance abuse treatment, community-based mental health, and housing. Thanks.
Great. There's some meta questions beyond the DCYF, so we're going to skip over those. There's a question around how many of the beds, I'm assuming PPI beds, are available to dads. I don't know that off the top of my head. Vicki, do you know how many of those are male?
I don't. That list is maintained by Healthcare Authority, so I might ask them, but I don't off the top of my head. I don't think very many. Most of them are not also available to dads.
That's right. There's a question about, will the regional substance use disorder professionals be doing the assessments as well? I don't know the answer at the top of that off my head. I don't know if you do, Vicki.
I don't know.
Okay, we'll follow up on that one. There's a question about, and Doreen, I'll turn to you. There's a question about how are longstanding cases or cases already in care being assessed? So on the kids who are lingering in care and likely or may not have entered care based on today's standard. Is there any, are we doing anything proactively there? Are the courts responding to anything there?
1227 really addresses shelter care. So it doesn't address long-term care cases. And so we're treating those the same as we always have. And that's just making certain that we are taking a look at the length of stay, trying to ensure that a child can find a permanency, whether that's a reunification with a parent, a guardianship, or an adoption.
Great. A couple requests for links. We'll get those posted. Talked about services. Is the lack of available services providers impacted the number of child removals in the last quarter? I'm not sure one could make that correlation or causal connection based on the data.
Doreen, do we see that? Do we see children removed because in part there's not services in the communities to help keep them safe?
I don't know that we can answer that question.
Yeah.
We don't have enough information about that.
There's a question, and I don't think this relates to 1227, and so we may need to follow up offline, Patrick, but on the long-term already in care, is there a push to return home? I've noticed return homes and now back into care. Talked about the balancing indicator available on our dashboard around re-entries into care. 1227 did not contemplate, like Doreen noted, it only contemplated shelter care. It did not contemplate length of stay or pushes back home. So there may be unrelated things happening that we're not prepared to address today, but we can certainly follow up, Patrick, more information or conversation. We've talked a bit about services and answered some of these questions. With that, I would just like to take a moment to say thank you all for attending. Some great questions, and I apologize we didn't get to all of them, but certainly can follow up. We'll follow up with in writing to them, and they'll be posted on the website. We're getting ready to launch a new web page around safely reducing the number of kids in care, preventing out-of-home placements, where this presentation, the slide deck, the FAQ, the quarterly data will be posted. We'll make sure the link to that page gets sent around as soon as that goes live, sometime within the next 24 to 48 hours. And then feel free to reach out if there are other questions. We appreciate everyone taking the time to join today and hope everyone has a wonderful rest of your afternoon. Thank you.